Hi everyone, welcome back to the channel. My name is Drew. I'm an accredited exercise physiologist and registered Chinese medicine practitioner. And I kind of love working in this kind of space of traditional Chinese medicine and exercise therapy, yoga, tai chi, qigong, pranayama, and then also in the modern exercise rehabilitation sciences because they just marry so well together. And in this video, we're going to be looking at a bit of a real world example or a case study of one of my clients who I am working with at the moment. Saw this person yesterday, and we're working on a back problem that this person has, and we're actually going to use her radiology report to break down what's going on in her spine, and then I'm going to use both Complete Anatomy and Muscle in Motion. So these two amazing apps. So we have Muscle in Motion here, and then we have Complete Anatomy, and there'll be links in the description for these apps. I really recommend you get them. And the reason I do that is because when people can visualize and see what's going on in their body, it really gives them empowerment to understand the process. Different structures have different rates of healing, so they take longer depending or shorter depending on the different tissues. So that gives us a good time frame. So you can tell somebody this might take 4 weeks to heal, this might take 6 months to heal, or this might take a good 12 months rehab plus another 12 months of remodeling. So then that also then informs the exercise prescription that we do. So I'm really in the space of prescribing exercise to help people recover from injuries. As a Chinese practitioner, I do acupuncture as well, so I do hands-on manual treatment. But in this video, I'm going to be focusing more on what can we do in terms of exercise. So I have the MR report here. This is the report. I have permission from the client to use this. All information is de-identified, so won't be disclosing who the person is. This is a female, about over 50 years old, and she has right-sided sciatica, and this has been ongoing for a little while. So she had this issue probably 2 years ago, quite significant sciatica. With treatment and exercise, it's resolved. However, unfortunately, she's had a flare-up where she was reportedly doing some gardening, and one of the classic kind of things that you'll hear is bending and twisting a lot, and then not so much in the moment, but like later that day started kind of getting mild ache, which by that evening it turned into the sciatica type pain. So I've got a MRI, and the most acute pain, you have to excuse me too, I've got a bit of a cold at the moment, so I'm just recovering from a cold, but I can still do videos. So my voice doesn't sound this raspy typically, and I'm drinking nice tea. So we have a MRI here, and it's a multi-level MRI. Goes from L1, L2, L2, L3, L3, L4, L4, L5, L5, S1. So let's break it down. So the first level here, we've got at the L1, 2, there is a loss of disc height and minor degenerative retrolithiasis. There is no evidence of focal disc protrusion or nerve root impingement. Okay, so first thing is we're going to know where the structure is. So L1, 2. So here we have first lumbar vertebrae and the second lumbar vertebrae. So we're talking about this area here, the space between the vertebrae, L1 and 2. Okay, so in terms of your back, that's kind of just below the rib cage line, kind of in the upper part of your middle back, upper part of your lower back. Okay, there is a loss of disc height and minor degenerative changes, minor degenerative retrolithiasis. So disc height, so this is the discs here. So you can see that you've got this space between here. So when you have disc height, it means that you're losing the actual height of the disc itself. So instead of having let's say if that was 1 centimeter space there, now it's only 5 mil. So you've lost 50% or however much it's going to be. Now that's an issue because these spaces here is where the nerve roots come from. And then when you lose disc height, then this actual space here is decreased. So essentially what you get is the nerve comes out between the bones, and then this space is, then you have a smaller space. So that means that the nerve can be potentially jammed up or impinged more easily. So you can kind of get issues with that. Now, unfortunately, to my knowledge, is once you've lose the height in the disc, very, very difficult to restore that height. And then the next big question is, well, what's the loss of height coming from? And typically it's a wear and tear type situation, or there is a disc protrusion that's occurred where, and we'll just go into that in a bit more detail, where you've actually lost the center part of the disc. And then so you get the disc in the center that protrudes out, and so you lose that kind of soft substance, the nucleus of the disc, and then that loses the height. And also hydration. So the disc themselves absorb water and various different kind of bodily fluid-based substances, and they're kind of like a sponge. When you get a lot of water in a sponge, it kind of expands, and then when you compress the disc, it kind of pushes all the water out. So the discs are kind of like sponges. They kind of, the shock absorbent nature of the disc, they absorb nutrients. So now the synovial fluid into the disc, that's where they kind of get their nutrients from, because they don't have a blood supply. And then if you're not moving a lot, or over time, or just as a product of aging, that hydration component of the disc degrades over time. So it can just be a natural part of aging in a sense. This particular person is very active, has done gymnastics and yoga all her life. So very, 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 very flexible and mobile, and good strength as well. So it's not really an activity-based condition. It's just a kind of process of aging. So this particular person's nearly 70. So if you image most people this age, you're going to get different things like this show up. And just because you've got a little bit of disc height loss, it doesn't necessarily mean it's a bad thing. It's typically is normally a natural part of aging. Now, the thing we need to be concerned with here is the term retrolithesis. So a lithesis is when the disc or the vertebral body starts to move forward or posterior. So you kind of get this kind of shifting of the vertebral body. And that's an issue there, because as if I put in the nerves, oh, that's the wrong one. We want the nerve system. So these are the nerves that are typically coming out of the spine. And we can see here, this is the space where I'm talking about. This particularly here is called the lamina. So sometimes when people have disc protrusions where the disc is compressing onto the nerve root, what they might do is shave this bone a little bit to provide more space, so it decompresses the nerve, which is one modern surgery which is quite successful for a lot of people. It's a good option if you've tried all the other conservative management, it's not working for you. But in this case, retrolithesis is where the vertebral body is going to shift forward or backwards. So an anterior lithesis is usually goes forward, and then a retro one is usually when it goes backward. So what you're going to get there is this space here is now going to shift this way. So then you're going to get jamming, not only from top to bottom, but from side to side. And so the space here is getting compromised because you're getting less height, and then you're also getting the lateral kind of movement on the vertebral body. So there's more opportunity for this nerve root, this whole nerve, different parts of the nerve, but it's all one nerve, getting jammed up and creating neural symptoms. And sciatica is the classic example of that. So in this one, in L1, L2, there is no neural impingement. But if we go down to L5, S1, there is a loss of disc height. There is a right paracentral disc protrusion with displacement and effacement of the descending right S1 nerve root. Okay, that's a big mouthful. So essentially, in this report, the L1, 2, 3, and 4 are all very similar. They've all got that kind of loss of height, a little bit of shifting of the vertebral bodies, but there's no kind of neurological symptoms. But when we get down to the bottom, to L5S1, so this is L5 sacrum, so S is for sacrum. It's on the right side, so it's coming out this side. And so this lady's symptoms are right-sided, so she's getting kind of referred pain into her butt and then down the back of her leg, which is the kind of classic sciatic referral kind of pattern. Right paracentral disc protrusion. Okay, so a paracentral disc protrusion. Flip around this way. So here we have the L3, L4 disc. So a paracentral would be the disc bulge is coming out behind, so more in the center, and in this case, slide to the right. So it's going to be in this region here, but not in this disc on the L5 disc down here. Okay. And that's going to be jamming up that sciatic nerve. Put the nerves back in. It's going to be jamming up this nerve here. Anterior of the fifth lumbar nerve. If you follow that pink nerve, it connects to this one. Zoom out. So this one coming through here, which then goes into the sciatic nerve. So you can get sciatica from multiple levels. You can get it at the L5, S1, or the more common one is the L4, L5, the lower vertebrae as well. So in this particular case, this patient or client has got a disc bulge kind of center right, which is compressing the nerve here. She's getting some impingement on the nerve. So what we need to be able to do is figure out, firstly, is there anything that she's doing that's kind of exacerbating this? Because sometimes it's not so much that the disc is compressing on it. It's just you keep putting the vertebrae in a position where it's closing the space and then it's getting compressed. So sometimes it's a movement or a habit or a posture where you just keep scratching the itch, if you will. You keep putting your posture in a bad position and that triggers or irritates the nerve. And we know this is probably happening in this case because it's not consistent in terms of the pain that this patient's describing is not all the time, all day, all night. It doesn't matter which position she gets, there's no relief. So that's a really good sign. That tells me we can manage this one conservatively. If she was getting this sciatic pain, and it didn't matter if she was like lying on her back, sitting up, lying on her belly, lying on her side, knees bent, legs straight, pillow between the knees. Doesn't matter if she's standing or walking, just the pain is just always there. That's a big sign that either it's a big disc bulge, like a big protrusion, or that it's compromised, either the height or the lumbar vertebrae is compromised to a certain level that the nerve's just been constantly impinged, and we can't reduce that kind of impingement. In that case, that is potentially a referral to a surgeon for a consult, because that may require a surgical intervention. Tend to go very conservatively because a lot of these disc problems, if managed correctly, do heal themselves over time. But the two big red flags that will really kind of dictate a referral to a orthopedic surgeon or a neurosurgeon would be this ongoing consistent pain, 10 out of 10 pain, nothing relieves it. Even strong pain medication doesn't really back it off, just makes you dopey, but you still feel the pain. And you're getting what's called a foot drop or muscle activation in the tibia anterior. It's just non-existent, so you can't dorsiflex. So you're tripping on your toe. And or that you're getting some incontinence type conditions because the nerves through here, they connect into the bladder, into the bowels, and also these nerve roots go down into the tibia anterior and the lower limb muscles, which affect gait. So typically if you get one of those three symptoms, so pain is not relieving by position, posture, time, or medication, okay, neural impingement, which is causing the foot drop, or incontinence, fecal incontinence or bladder incontinence, they're typically a warrant a referral. But in this case, don't have any of those signs. The ascitic pain is intermittent and it kind of comes and goes. So what we need to do next is work out, is this a flexion or a extension condition? So to do that, we're going to jump to the other app. So for this app, if you want to find it, we're in Muscle in Motion, the yoga app. We're in Asana, and this is actually in the Child's Pose Balanasana section. So if you go to that, you'll be able to find that. And it's in the theory videos. This is theory video number 4. So I'm not going to go through all this. I want you guys to support the app and get your own copy. But this is where you'll find it if you want to have a look at it yourself. It's a great video describing from Dr. Gil Solberg and Amit Gal-Allen. Always like to acknowledge the creators. So here we are looking at the vertebrae. So we've got vertebral bodies here, and this is the disc. So imagine this is your L5, S1 kind of region, although the shape is slightly different. Okay, but the principle is going to be the same. It's a nice kind of overview of the discs. Okay, we have the vertebral column. So when the vertebrae stack upon each other, the lumbar vertebrae, thoracic vertebrae, cervical, that's called the vertebral column. And the number one job of the vertebral column is to safeguard or provide a protective structure for the spinal cord. Okay. Spinal cord is a very sensitive structure, and so it's surrounded by bone, essentially, so it's really strong. We also have these big ligaments, so the anterior ligament and the posterior ligament. So these are really strong, thick ligaments that go up the front and the back of the vertebral body, and that provides also stability and protection. You can see how they wrap around the disc. Now within the disc here, we have the disc nucleus or the nucleus pulposus. And this is often described as like a toothpastey consistency. It's kind of like a gel. And part of that gel is it provides a little bit of that kind of shock absorption component to the disc. And then the annulus or the tough outer ring of the disc here is quite strong. So if I jump back into complete anatomy for a second, we highlight a disc here and we go to isolate. Let's say hide others. There we go. So this is looking down from the top of the disc. So here you've got these concentric rings. It's like a tree trunk, really strong connective tissue, cartilage. And then in the middle, you've got the soft gel, the nucleus pulposus. So a disc protrusion is typically where this soft gel pokes out through the disc itself. Now, for that to happen, that means that the disc, the cartilage, needs to be torn or ruptured, which is like a ligament tear. So think you do a ligament tear in your knee, you do your ACL, your MCL, your PCL, like ligament kind of cartilage. Typically those ligament, when you do them, they're quite painful. They do have nerve endings. They're quite sensitive areas. And then the healing for a good ligament tear is, you're looking at a minimum of 6 months of healing. So when someone does a disc, okay, if they don't have the actual protrusion compressing a nerve root, there's still got this healing that needs to happen. And then often what will happen is that if the disc is starting to protrude out, or it's like leaking out into the side, then the body does activate its immune system, and it will phagocytosis, Pac-Man up the debris, and over time basically clear it out, which is super cool. The trick is you've got to provide the space where you're not keep irritating and compressing it and keep pushing that disc out. So you've got to rest and then appropriate loading and exercise, which is where I come and help people do that loading. So we jump back to complete anatomy. Okay, so nope. So in a normal spine, you've got a slight curve here. It's called a lordosis. Okay. And what we're looking for here is the way the discs are organized, that they're sitting on the actual disc in a way that it's fairly balanced. So you'll see as you go into flexion or extension, or forward bending or back bending, the shape of the disc is going to change and the compression is going to change. So here you can see this is the back. So this is an extension movement. So you can see here that the nucleus pulposus is getting pushed forward. So you're getting compressive forces on the inside, closest to the spine, and you're getting the movement pushed out to the front of the vertebrae. So if you had a disc bulge here, that would be called an anterior disc bulge, and they are quite rare. You don't see them very often. The only time I really see them is if someone's been in a fairly severe accident, like a motor vehicle accident. They're not the typical kind of wear and tear disc bulges you'll see. So at the end range, you can see here that the vertebrae are fully closed. They're in their closed position. So we take it back. So this space here, okay, when you go into back bend or extension, if you're just like leaning back, creating an arch in your lower back, everyone's range of movement is really dictated on how much space you've got in this back bend here. So once you kind of get to that space where they fully close down and you've got bone on bone, essentially, you can't go any further, and that's your natural range of movement. So a lot of flexibility stuff that you see on the internet where people are getting really crazy flexible is, one, they do a lot of work, and two, you have to have the anatomical structure to allow your joints to be able to do that. So it's a little bit like everything's a trade-off. The closer your joints are, the stronger they'll be, so more stable, but the less mobile or flex you are, versus the bigger space you have between these vertebrae, the more mobile you are, but then the less stable it becomes. So everything's always a trade-off. One's not necessarily better than the other. It is what it is. The key thing is you can't change the shape of your vertebrae once you kind of get into your middle age, 20 into your middle 20s. Your skeletal structure is basically defined. You've got what you've got. So you've got to, if you're going to be really flexible when you're growing up in your teenage years, that's the time to really do a lot of the training for that, so your body can grow into the shapes. Okay, so we keep going. Now from here, the angle between the vertebrae transfers the pressure onto the disc to the front. So yeah, you get that pressure to the front of the disc here. Okay. Pushes the nucleus forward, and that potentially could cause an anterior rupture if it's too excessive. This is normal. The spine's designed to do this. That's why you've got this soft gel in the middle to be able to transfer the load and the forces. Now, if you kind of like forward bend, like you're going to touch your toes, you're going to shift this nucleus now towards the back, towards the spine. So then if you do a really strong flexion movement, okay, you're taking the load of the torso and essentially it's going into these segments here. And that can, over time, encourage this kind of flexion, this nucleus pulposus to move out the back here. So in our client's case, our female who's got the right-sided paracentral disc protrusion, this has happened to her. So at some point, the disc has ruptured or torn, and some of the nucleus pulposus is starting to push out. And depending what shape she gets into, it compresses the nerve, not the spinal cord in this case, but the nerve root coming out of the spinal cord. But we know if she comes off that flexion, if we come back here, the pain minimizes in her leg. I know this because we did the testing and the assessment yesterday to establish this. So what we're trying to do is figure out, is she flexion or is she extension intolerant? And every kind of flexion position I put her in, doing what we call a provocation test, that would increase her sciatica symptoms. But when we took her out of flexion and took her into neutral or into extension, that was actually quite relieving. So that tells me that we've got a good opportunity here to help encourage the disc to heal by putting it in the right position and providing the right exercise prescription over time, that we can then take away the issue. Now, in the assessment, we did a full hour yesterday, and big part of the assessment was like, once I figured out that she was flexion intolerant, the next thing I wanted to know was like, what's causing that? What's causing her to be compressing her disc like that? And so being very active and being keen to maintain health, this particular client had started doing some weight training at home. And so I just got her to run me through her exercises, just as she's doing them, so I could look at her technique and her form and her posture. And it became very apparent that she was doing two things in her exercise program where we're actually creating this problem, we're exacerbating it. The first one, she was doing a standing dumbbell lateral flexion. That's where you hold onto a dumbbell and you just lean out to the side and then come back up. Lean out to the side, come back up, which is a great exercise for strengthening the quadratus lumborum. So the intention is good. So that's the main back muscle. But when she did it to the right, she was essentially creating this shape on the right side. So it was compressing that nerve root down. And because she's got loss of height space and a disc bulge there, that was compressing on a nerve, creating the injury or creating the symptoms. So the first thing we did is we switched out that exercise for a side plank against the wall in neutral position. So in getting those obliques and that quadratus lumborum active, but in a way where we're not compromising the nerve root coming out. And she could do that quite well. No pain, no symptoms. So we switched that exercise out. The other exercise she was doing was a dumbbell overhead press bilaterally. So two dumbbells, 2 5-kilo dumbbells. Remember, this is a 69-year-old lady. Pretty impressive doing 2 5-kilo dumbbells overhead. But the issue that she was having is when she had her right foot back, so weight on the front left leg, so split stance, weight on the back right foot. And when she press up, she would lean back into extension. And that would irritate her quite significantly as well. Now, typically an extension would look more like this. Okay. So she doesn't have an anterior bulge here, but what she's doing is she's closing down this space. So she's going into full back bend, essentially, almost full back bend under load. And she's compromising that space in here. She's closing it down. So remember, she's got loss of disc height here. So she doesn't have a lot of room and she's got that bulge sitting there. So she's basically just jamming it up. And so what we did there was we just didn't change the exercise. We changed the technique, taught her how to engage more of a neutral brace, brought her feet back into a parallel stance. Okay. And then just refined her technique so what she was Pressing up, we went to, instead of bilateral arms, unilateral, so one arm at a time. Inhale on the way up, and then exhale, core bracing on as she's pressing up to really stabilize, and then not dumping into her lower back, so she's not compressing that nerve root. And once we went through that, she was no symptoms there at all. Other exercises she was doing, really good, long history of yoga, loves her yoga. And the other thing that she was struggling with in her yoga were things like Warrior One. So let's go into asana. Now, yoga is an amazing exercise system. I practice yoga myself daily, or yoga or Tai Chi daily, or yoga or Qigong, one of those. 2 to 3 times a week, I'm lifting weights. Okay, so here we have classic Warrior One, like a high lunge stance. Now, what we'll see here is when she had her right leg back, she was essentially jamming up that right disc, that right nerve root again. So as you can see here in this demonstration, when she lifts her arm up like this, you do a back bend, you are an extension of the spine there. And because this right leg is back and there's a slight rotation in the torso and in the pelvis there, essentially she's creating that closed down compression in the L5 S1 nerve root, and that's creating symptoms. Or she would feel very unstable in that position. And the reason she was unstable is because the body is very wise, very intelligent, and it's basically saying, don't go there. We're not ready for this yet. Please adjust. And one way the body does that is to inhibit muscles. It's basically saying, no, not doing that, not today. If you go there, if you make me do that, something's not going to end well. All right. So the body's very, very smart. And so when you go too aggressive with your rehab, or if you do the wrong thing, sometimes what the body will do is it'll inhibit muscles that's going to further injure a structure. And then what happens then, if you persist with it, the body will then have to make a compensation to try to do the movement another way. And it's not perfect, it's not ideal, and you just wind up getting really messy. So what was the solution for this particular posture here? So the solution we did for this one was actually quite simple, is that what we did for this back leg, come back here. Okay. A big problem that people have in Warrior One or the high lunge is that when this back leg comes out into extension, hip extension, the SIJ area here gets fully closed down, and that L5 S1 nerve root is just coming out through the space in here. Okay, so the way we kind of adjust that for this particular person is we just take the stance wide. So you take a wide stance out here, and then you just allow the foot to be a little bit more turned out, and you just adjust a little bit so the person feels comfortable. And typically in a lot of classical kind of yoga, they teach you to kind of like try to square your hips up, so you like how your hips square to the front. And what that does for a lot of people, it just jams up their SIJ and their lumbar spine because they don't have the mobility or the range to do that. So you just take your foot out a little bit wider, have a slightly wider stance, and you don't be quite as aggressive in that kind of pushing into the rear foot. The other way we can kind of address that would be to not come into full extension. So you could release the hands down and just bring the torso forward a little bit. Okay, or kind of reach more up on this ankle through here, and then you'll take away a little bit of that extension. Okay. I'm not a huge fan of that because you do need to be quite strong in the core. So I prefer to adjust the rear foot. The other way we could adjust this is to actually bring it down into low lunge. So have the knee on the ground, similar type of shape, asana, but then you'll be more stable, and we can then also adjust the front foot so you've got a wider base of support and give more space into that SIJ joint. So we did a little bit of work on her yoga asana as well, and a couple of postures we had similar little tweaks to do. So the whole idea there is just understanding the injury. So in this case, the L5 S1 nerve root problem. Okay, what's creating it? So in this case, it's flexion intolerant. So too much forward bending, pushes that disc out further, and then too much back bending fully compresses that disc down, the vertebrae down, and closes the space, and that jams it up. So too much either way for this particular person could be irritating. Once we stop doing the exercises, it's irritating nerve, it'll settle down. The body will activate its own innate healing process. It'll Pac-Man up, and over time start to clean up that disc. And we should be able to get to a good result. Long term, because we've got a lot of structural changes in the spine, essentially the loss of the height and the retrolithiasis starting to occur, range of movement is starting to decrease. So we need to go into a more of a mindful kind of process where we're exercising, we're doing yoga, we're doing our weight training, we're maintaining really good alignment and posture. The next thing we would do is start working a lot of breathing exercises, because when you're breathing, you're moving the spine correctly if you breathe correctly, and then integrate breathing technique into asana and into weight training. So then she can find the natural movement in her body based on the exercises that she loves to do. And we've got another session next week, and we'll see how she's traveling, but I'm fairly confident. She's a really good client in terms of takes on board the feedback, takes on the coaching, wants to be healthy, wants to do the right thing. She had a good kind of sense that there was something she was doing with was creating the problem. She didn't know what it was. And, I was really grateful to help her resolve that issue for her, which is part of why I love what I do. So if you have any questions about this presentation, please feel free to drop a question down in the comments. And really appreciate your time if you got to the end of this video and your willingness to learn. And we'll look forward to seeing you on the next video. Okay, thank you very much.